today's talk becomes very, very important, that because lots of people are doing ERCP. What is the cannulation rate? If the cannulation rate is not up to the mark, what is the exact reason? And what exactly to do in case their cannulation rate is not exactly up to the mark? And how can they do, what can they do to improve the cannulation? The reasons of failures, the avenues where they look into. For that, we have requested old friend, Khalid Hassan. He is medical director and director advanced endoscopy fellowship at the Center for Interventional Endoscopy at Advent Health Institute for Minimally Invasive Therapy in Ford Hospital. He is a mentor. We have been his students in the endoscopic ultrasound. We learned endoscopic ultrasound from him, and we have attended so many sessions with him on ERCP and EUS. Khalid, all yours.
Assalamu alaikum. Thank you, Gas Bhai and Saad Bhai and Junaid and everybody else. Today's talk, actually, we have done so many presentations on this forum now. So this is basically kind of recaps all those sessions, especially with regard to ERCP itself. So what I'll do is I'll just go over what should be the goal of really ERCP. And the goal is to achieve excellence in ERCP practice. And at the end of the day, a good ERCPist should have a cannulation success 95% or beyond. So I'm going to be just basically talking about cannulation. And its failures and what to do, what are the reasons of failures, and how to overcome those. I'm not going to be talking about the other issues after you cannulate, how to do the therapy, if you can't take the stone out or whatever, if it's a stricture. So those are become a separate topic. So the whole really topic here is going to be how to achieve cannulation in the large majority of the patients. So I won't go over these indications. Want to stress, and I have said that before, it has been said by others as well, that ERCP should be almost exclusively therapeutic procedure. So really not much role in diagnostics, maybe a little bit, but not much role. And at this point, I would just basically say it should be exclusively therapeutics. What are the key principles? You have to have appropriate patient selection. And just remember that there's no single technique that is uniformly successful or uniformly applicable to every single patient. So if there is one technique during conventional cannulation does not work, then don't obstinately be persistent with that, because you have to change something to make it work. And the goal is to have a consistent atraumatic cannulation. And if conventional technique doesn't work and our core technique doesn't work, then what would be the appropriate advanced technique? So there are different advanced techniques. I'll go over those as well. And if all else fails, what would be the next best approach, which may not be endoscopically, but what could be endoscopically, may not be endoscopically. So main thing is really, as a principle, we follow in medicine, as a physician, our utmost goal and responsibility is do no harm. And honestly, the hardest thing to learn for us, and endoscopist or a surgeon or as a physician, especially those who are in procedural specialties, to learn when to quit for patients' benefit, our benefit, and everybody's benefit. So how to succeed? I'll talk about core techniques. You have heard about core techniques previously from me. I'll go over those briefly, then talk about advanced techniques. And then challenges happen in patients who have altered anatomy. And then I'll talk a little bit about EUS and IR surgery and all those, what could be utilized to be successful. You have seen this slide before. the only way you can become a really successful ERCP is that you have to become a papillologist. That means you have to talk to the papilla, you have to understand its anatomy, you have to understand its angles and axis really before you touch it. And always be gentle with the papilla. You cannot keep beating upon it and then hope that it's not going to beat up on you. It's always slow, calculated movements at the ampulla, which are going to increase your chances of selective cannulation. And as I said before, no one technique fits all situations. And I'll talk about the different techniques in a little bit. So I always have mentioned that really the biggest secret of successful cannulation really is a position, 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 and then gentle small movements. Uh, this is, I have mentioned about this before as well. So in the interest of time, I wouldn't go over all majority of my slides and just will be skipping some of those. So just remember that sometimes we get a report, or sometimes we hear the like papilla was so small, opening was so small to get in. So that really doesn't exist. If there is a bile flow, there should be a way to cannulate that orifice. And successful cannulation really never depends on pushing harder. It's always about axis and angles. And if you're distorting the papilla, don't keep pushing on it. And usually when you are challenged, the best way to get a selective bile duct cannulation is tip up, not to advance the catheter. And if you look at the papilla, you have to align the sphincter tone with the papilla. It has to be perpendicular to the papilla. And usually the teaching is that standard or conventional teaching is you go into the second part, shorten the scope and lock the small wheel. Really, that's, I think that's just over exaggerated, and main goal is to get into the best position to touch the papilla, be it short position, long position, semi-long, doesn't matter. It has to be in the best position and stable position to touch the papilla. And about locking the small wheel because you are afraid about falling back, that I would advise against that unless it's really unstable, because that hinders your small movements which you need sometimes to get into the right orifice. So after you have cannulated, yes, then you can lock your small wheel. But also remember that what's the worst can happen if you don't lock the small wheel. You can you're going to fall back, and you can go back into the second part of the duodenum. Other what I say usually advice is, like, if you are afraid that you're going to fall back, if the scope wheels are facing your chest, then really the scope kind of hugs around the duodenal apex, and you don't fall back even if your wheels are unlocked. And again, about the conventional, if it's a regular normal anatomy, the CBD usually is at 11 o'clock, and pancreatic duct is at 1 to 2 o'clock position. But unfortunately, not all the patients read the books, and we really have to deal with the individual papilla individually. We always talk about accessories, sphincter tone, cannula, and there are so many accessories available, and not all of those are really available to everybody. So what I would suggest is really be inquisitive, expose yourself to broad spectrum of available accessories and see what is available to you, and then select that one based on what works best for you. I wouldn't talk about this either. You have heard about that before as well. There are different ways, either wire guided or just seating the catheter. These you have seen this slide before, and so I wouldn't go over that again. So these are some pictures. These are very straightforward papillas. You can see it's kind of more like a flat. There's nothing bulging out much of it into the duodenal lumen. So they usually are a straight shot, and bile duct at 12 o'clock, pancreatic duct at 11 to 12 o'clock, pancreatic duct 1 to 2 o'clock. So usually should not be a big problem. The if that when is the problem? The problem happens is when papilla is a little bit different, and what that makes the cannulation difficult. And really, there is not much consensus. Like what is really a difficult cannulation, difficult ERCP. But having said that, there is some agreement that if there are more than 5 attempts at cannulation, or you have spent more than 10 minutes, or there are 4 PD cannulations, that makes it that difficult. And in those cases, when the conventional technique is failing, more time you spend, harder it becomes to get into the desired duct, and you put the patient at risk of complications. Longer it takes, you become a little bit nervous as well and start sweating. So the chances of running into a trouble are high. So that's where it starts. You have to start thinking in the back of your head, what is really wrong? Is it something wrong with the equipment, sedation? Are these patient factors, which could be anatomy of the papilla, post-surgical anatomy? And then very, very important is the operative factors. And really, you cannot solve the problem unless you pinpoint the problem. So at that point, when you're having this much difficulty in cannulating, instead of beating up on the papilla or getting angry with your staff or start blaming your equipment, just take a deep breath, be kind to your staff, be kind to the scope, be kind to the patient. Uh, just take a deep breath, think what is going on wrong, what could be wrong, and then solve that problem. And if there is if you've identified the problem and you can't solve that at the moment, then there is always another day, there is always another person, there is always another colleague, and there's always another type of procedure which could be done to help the patient. The goal is not to harm the patient. So with regard to the papilla itself, you have seen this slide as well. So if conventional technique, it's not working, you don't think there is a problem with your technique, you don't think there's a problem with the patient overall, or sedation is good, no other issues, then the reasons of failed cannulation could be the papilla itself, the anatomy of the papilla. So these, I have mentioned these before on previous talks as well, so we'll go over those briefly. What we call a Sharpie papilla, up and over papilla, aberrant relationship between the biliary and pancreatic orifice. I will show pictures of those. There could be a separate openings, and obviously ampullary or periampullary diverticulum can make things worse. Sometimes it makes things really easy. Other times it can make the things worse, and then patients with the altered anatomy, be it gastric bypass or Bilrod 2. So this is a Sharpie papilla. What it really is, there are so many folds on there, and it's you see the opening, you see the bile coming out of that opening, and it's not letting you in. So that is quite frustrating, because really the reason is there are so many folds. in that, and there is not a single long channel in there. So it's more like maybe a kind of a zigzag in there. So you have to really kind of align all those folds. In my personal experience for these type of patients, the straight cannula works much better to align all those folds together and get in there instead of sphincter tome. So that's my personal preference, personal experience. Obviously, there are a lot of people among the audience who are doing ERCP. They're really good at it. And so everybody has a different experience with those. But bottom line is just stick with what works for you. This is another example, which is up and over papilla, what we call. It is also when you see a bulge at the papilla and you look, papilla looks very nice, bile is flowing, but you see a bulge over that. It is also called camel's hump. When you see that, so just get ready. It may, even though it looks straightforward, but it may not be a straightforward cannulation. In these type of cases, usually you have to do a different type of movements. And those movements are, you can see that hump, which we saw in that previous image. This is the hump, this is the hump. This is a little bit different, but this is really a best example of up and over papilla. When you see this kind of a hump, that would be a trouble. So because you cannot go straight in that papilla. In that papilla first, but you have to, if you use a sphincter tome, you go in, sphincter tome is facing a little bit upwards, it's always going to hit the ceiling of that, or the roof of that papilla. And with the sphincter tome, if you bow in those, that's a problematic. You are making the situation worse for yourself. So in those cases, you engage the papilla and then pull back on scope and flatten the angle. If you move the big wheel a little bit away from you, that flattens that angle and gets you to over the hump. And once you are over the hump, then you advance the scope a little bit, and that gets you in. So it's never about pushing. It's always changing your axis and angle based on the shape of the papilla. And other thing, I want to go back a little bit. I can't stress that enough. I really can't. And that we know that orifice is obviously very important. You have to take a look at the orifice, be able to know where you're going to touch. But for me, equally important is what's going on above the orifice, what's going on over here. This whole papilla, especially bulgy papilla, until it meets the duodenal wall. So my rule of thumb is I take a look at the orifice, I take a look at the duodenal wall, I take a look at these folds. What I do is, like, wherever the papilla is touching the duodenal wall and this concave fold right there, in this case, for me, I see that if I draw a line from here to the center of that fold where it meets the duodenal wall, that would be my angle of bile duct cannulation axis. Here, okay, it's a little bit bulgy there, so this would be the angle, but this you have to change accordingly to the position of the inside of the papilla. Here, I will draw a line from here all the way up to here. So this is my line or axis of cannulation. So this is for every papilla. I always study that area or study the papilla. And I actually advise my fellows, you can freeze your image for 30 seconds and tell me what your plan is. What do you think, which way the wire is going to go? So it's an imagination. You have to really get into the papilla to figure it out how to deal with it. So this is that example of up and over or camel's hump papilla. And here you can see if you keep pushing up or keep bowing is going to take you this way. It's not going to take you this way. So once you get in there, you have to let the wheel go a little bit, or unbow the sphincter tome. So that gets over the hump, and then you are once you get in here, then from there it becomes easier. This is you have some of you already have seen this video before, but this is kind of an example. Here my axis is going to be from here to here. This is my line of cannulation. Look at the sphincter tome, how I'm doing. And then I realized it was not like a 100% example of up and over, but again, I realized that, okay, when I'm putting a contrast in there, it's going a little bit to the right, and it gave me an idea that really I need to change my axis a little bit, change my alignment a little bit to get in there. And then other thing would be uh, other reason for failure could be that biliary and pancreatic orifice kind of a little bit switched. There, one is on the other side, other is on the other side. 2 days ago on Wednesday, I had this patient come, failed cannulation. They had put a pancreatic stent, but it could not get into the bile duct. And that was a perfect example of an aberrant orientation. The actually biliary orifice in that case was right here, and the pancreatic was here. So literally they were completely swished, and actually more than swished. Biliary was right at the bottom. So just keep in mind that there could be a different orientation. Doesn't happen quite often, but can happen. There could be separate openings. If you go into the PD and keep going in there, just take another look at the shape of the papilla. And there could be other reasons as well, but this is also, I can't stress enough to study the papilla, just because for that reason, that there may be two separate openings, and you can see from the very beginning, and then becomes a piece of cake for you. And then these are periampullary you have seen. These ones, actually, let me skip that video. This one is a little bit different in the sense, a little more difficult. You can see ampulla is inside the diverticulum. So this one, obviously, you can't work with it by pushing or anything. And also here, while I'm doing this cannulation, I'll talk about another topic. I think we all want to talk about the wire-guided cannulation. I think we are overstressing that too much. And yeah, it does work, and it may be less traumatic in a sense that you don't want to inject into the pancreas. But at the same time, I'll play this video while I keep talking. At the same time, a case is like a pancreatic cancer, bile duct stricture, pancreatic duct stricture. And if you go with the only wire-guided cannulation, if you happen to go into the pancreas and the wire is a little bit bigger, it goes into the side branch, it can perforate the side branch. So you really didn't do any good for the patient. You caused perforation of the side branch, and that led to the pancreatitis. What I'm trying to get at is, yes, wire-guided cannulation is taught a lot, and but I think we are kind of over stressing that, and at times it's good to have a little bit injection to get a roadmap where you really how you need to adjust your wire or your cannula to get into the bile duct, because not always the wire guided cannulation is going to be the best way to go with. This is another video which you are watching. You have probably some of you have seen this before. And the papilla kind of inverted inside the diverticulum, and use the there are different ways to deal with those. A lot of ways have described, but the best what works for me is by clipping the fold and everting the papilla outside the diverticulum. The people can dilate the orifice of the diverticulum to get in. You can fill up the diverticulum with water that flips it out. You can use a pediatric biopsy forceps along with a small cannula, both through the same channel. and forceps grabs it and pulls it out, and then you can cannulate with a catheter, small cannula. This is ampulla, which is kind of facing downwards, doesn't want to talk to you at all, and looking other way. So you really have to try to negotiate with that these kind of papilla, and you have to get underneath, engage the orifice, and obviously pushing is never gonna work here. So you have to pull it back towards you to be able to engage and get in there. One quick question, Ghiasbhai, you get, the connection is still working properly, right?
Yes, connection is working perfectly fine.
Okay, thank you. Sorry. So this is case where the papilla is facing away from you. So here you can see that there are a lot of folds there you have to cut through, because there's a lot of portion of the papilla is inside the lumen, and you cannot really do a therapy unless you really cut the sphincter completely, or do a sphincteroplasty interest of that. But this one, I have described this before as well in previous talks, what I call a plastered septum. When you are inside the, when you can look at the papilla, looks very straightforward. There's a nice orifice. You go in, even though you feel like your angle was inside the, in the direction of the bile duct, but you end up in the pancreatic duct, and you end up over and over and over into the pancreatic duct. So even in that case, just remember that bile duct orifice is here, pancreatic duct orifice is on this side. You first touched it, and you just got into the pancreatic duct. What that did is you push the cannular sphincterotome, or advanced, I should say, the cannular sphincterotome that move that septum upwards. Now the bile duct orifice is stuck between this wall, duodenal wall, and the septum, which is just all the way up to the roof of the papilla. So bile duct between the roof of the papilla and septum, but you don't see it, and you keep cannulating pancreatic duct over and over. So the best way to really deal with that is using a wire tip, and right at the upper edge of the papilla, and use the wire tip to get separate those bile duct. So those were, first is the standard techniques, and then papilla is, even though it's kind of a different type of papilla, you have used your all imagination, all tricks, and you understand the anatomy of the papilla, and then still are not really able to get in, then what to do. If you keep getting into the pancreatic duct, then the technique, which is called the double wire technique, you can leave the wire into the pancreatic duct right here. And what that does is that kind of straightens the papilla for you, and then use take the cannula out to get another wire, load that into the cannula sphincterotome, and then really use that to your advantage, straighten papilla by using the second wire to get into the bile duct. If that fails, then you can put a PD stent. PD stent, you have to be careful about that. One thing is, obviously, you got to know how to do that. That's not what I'm talking about. What I'm talking about is, if you decide to put a pancreatic stent and the orifice is really small, and you end up putting a 5 French, because these are the most available stents in Pakistan and maybe in many other countries. So you kind of completely occlude the orifice. So then you're going to have a hard time really getting in there with the wire over the pancreatic stent. So in my case, I usually use a 4 French, and so I still have some space there, even if the papilla is small. Usually, if you end up using a bigger stent, then wire above that may not work, and you have to go to your next option of needle knife or pre-cut, which I always, if I have a choice, I almost always prefer over the pancreatic stent than freehand. Then there is a other thing which you can do, a septotomy, but septotomy is going to be obviously without a PD stent when you are in a pancreatic duct with the wire and sphincterotome. Then you cut the septum. There is a very fine way to do that. You are not doing a pancreatic sphincterotomy, you are doing a septotomy, because if you are too deep into the pancreatic or pancreatic sphincter and you cut that, you made it worse for yourself. You did a pancreatic sphincterotomy, you're going to keep going in there. So septotomy is a very fine way to do that. And just be careful about that. And then in pancreatic cancer, sometimes you can do a fistulotomy as well. So these are the techniques you can utilize after your conventional technique has failed. This is one of the needle knife. You can see here, one thing is, after I put the stent in there, I don't just start and just go crazy with the cut. What I do is I take the knife, a needle knife. I take that out of the scope. I ask my tech to show, give him the needle knife, means show it to me, see how long that is. And then I do few movements without cut, obviously not touching it, like what direction I need to cut, which direction my knife is going. So I'll go back a couple of times without cutting back and forth, and then utilize that angle and that axis to cut it right above from here upwards, or you can do from up downwards. Also remember that really you have to cut a little bit deep. The goal is not to expose the mucosa. Goal is to expose deeper in there. And so to go deeper in there, you have to cut a little bit deeper, not just the superficial cut. And here you can see that orifice looks like biliary orifice is going to be somewhere right here. So cutting a little bit more. And after you are done with the cut, then either you can use the cannula to gently probe around, or you can use even a wire tip to probe around a little bit. So just probing a little bit and then getting in there. This is an other example. I think that may be enough for this. So I'll move to the next slide. Why I want to place a pancreatic stent is one of the reasons is it provides me a direction of the cut. It kind of straightens, stabilizes the papilla for me. And also, main goal, one of the major complications is the post-ERCP pancreatitis. So it helps me protect the pancreas. And any good thing goes wrong during the case, bleeding happens, I can't get into the bile duct, I'm not at least worried about the pancreas. I did whatever I could to really protect the pancreas. So that's why my preference is, if I'm going to do a pre-cut, then I'll go over the pancreatic stent. I'll skip that as well. So all that other, those are the core technique or a standard technique, and then some advanced techniques. And then this is a patient with a really gastric bypass. Those are not easy patients to deal with. There are different ways you can do. If they still have a stomach, you can do a EUS guided, but this is a double balloon ERCP guided. And here you can see there's no elevator. This is a 155 centimeter interoscope. And in this case, it's just like a Billrod 2, and these are really not easy cases to do. One way is to do with a double balloon interoscope. Then other ways you can do with EUS guided access to the excluded stomach, or remnant, what we call an edge procedure. So that is one way to do those. So those are the different reasons where you can fail, and how to overcome that. If everything fails, not able to, then our other options are EUS guided help, which I just mentioned about the edge. In cases of pancreatic cancer or chronic pancreatitis or pancreatic duct stones, where we are not able to achieve cannulation standard way, we can do a US guided pancreatic duct drainage or bile duct drainage. That's a whole different topic, but and because different ways to do that. If they don't work, then obviously we have to look for help elsewhere. The help could be with the other specialties, with the interventional radiology or surgery, PTBD, or they can place a wire for you, and you can just use that wire as a guide and get into the bile duct. And obviously surgery comes to in these especially post-surgical aneurysms, altered aneurysms, where you may have to do an intraoperative systems. Before I go towards the other slides, and I just want to show you this. This is our study, and some of you are already familiar with that. How often really an advanced technique is required. Mainly, I'm talking about beyond the ERCP, other techniques like EUS guided or IR or surgery. So this is a study of 1,000 patients. You can see 524 native papillas. Papilla were reached in 518 and could not be reached due to various reasons, post-surgical or duodenal obstruction for the tumor, whatever the reason was. But if you look at the cannulation success, standard cannulation, 87%. Standard is not using double wire, not using pre-cut, not using pancreatic stent just to cannulate. And so that's a standard technique. Advanced technique is needle knife, pancreatic stent, double wire, and rest. So here you can see the needle knife really came about, the use of needle knives really came about after 85 to 87% conventional success. So bottom line is like if your cannulation rate is only 50%, or my cannulation rate is only 50%, I really have no right to even ask for a needle knife or use that. And a lot of people I know of, and they really just use the needle knife in majority of patients, and I think I do not necessarily agree with that. But what I'm trying to say is like if you're not able to really achieve cannulation in up to 80% of the patients, 80% of the papillas, think how you can improve your cannulation with the attachment with somebody or guidance from somebody who is more experienced than yourself. So keep that in mind. And here at the same slide, bottom line is in this study, EUS guided biliary drainage was needed in only 3 out of 524 patients. So there's a lot of talk about EUS guided bile duct access, drainage, and I did a webinar a few weeks ago on that as well. And bottom line is ERCP is here to stay in the right hands. It's not going anywhere, and it's all still going to be primary modality to gain same with the pancreas as well. So this algorithm from Dr. Reddy. And here there are a few, they have kind of tried to like simplify, but you can see here PD cannulated, PD stent, CBD cannulation. I think you can follow with that, but just follow that after really you feel like you have attained competency in bile duct cannulation or ERCP. The other, if there is a if you continue to fail, obviously, if a problem with the equipment, sedation, you can take care of that. You understand that patient factors I talked about. I want to talk a little bit about the operator factors and operator. We are the operator. What do we really need to achieve before venturing into these advanced techniques? Societies and a lot of people put the numbers of these many ERCPs you really need to do before you become competent enough to do those on your own. So I think that putting a number is really not the right thing. And especially in procedural aspects in medicine, it is not driven by the numbers. It really is driven by the competency. Numbers range from 200 to 500, and some people may be competent enough with the 200, other may need 500. So it really varies from trainees to trainees. Bottom line is, as I can't stress that enough, should be able to achieve cannulation with the core technique in 80% of the cases, and overall cannulation rate should be 90%. The people who go into practice who are not who are half trained, what happens is then eventually patients end up paying for their continued learning on the job. And that is really not fair with the patients. That if our family is a patient, that's not fair with them, and we wouldn't want that either. So we need to continue to put time in research. We need to enhance and continue to improve the quality and safety of our ERCP practice. So how I do deal with the ERCP cases is I meticulously apply a primary technique or core technique. In my mind, even if it may not be counting in my mind, I keep a track of all my attempts and look at time, how much time I have spent. And for me, I would consider early change to alternative technique, but really depends on the situation. By alternative technique, mean is advanced technique, double wire, PD stent, needle knife. And when I get to that, I will think about procedure objectives. I'll factor that in. I'll think about what the alternatives are. I will think what's the best for the patient. It's really, really hard, but I would be prepared to quit if it comes to the patient. For everybody, and including myself, use the strategy that suits yourself and provides the best end results for your patients. If not able to achieve what you need to achieve, seek help from experts. You would know that there are experts, and we all know in our heart that there are people who are better than us out there, and we should seek advice from them and should seek help from them. We can transfer the patient to the other tertiary care center where people have more experience. Work with the colleagues from other specialties like interventional radiology, surgery, And it's okay. It's okay to fail. We all fail. There is no problem, and there is no shame on failing as long as we don't do any harm to our patient and who take care of the patients. And believe me, some of the best decisions you would make in ERCP is to stop the procedure when it's not going right. Thank you.
Thank you, Khalid. Thank you. It was an excellent talk. Brilliant as always. There have been a couple of questions. How about the role of assistant cannulation? Dr. Tran has asked.
Can you repeat that question? Sorry.
What is the role of assistant in the cannulation? How important is the training of assistant in the ERCP suite?
So in 2 words, extremely important. Okay. And so it now depends on the situation. We have a really trained technicians, and they can help you through the tough cases. They can guide your wide through the tough cases. So they need to understand what's going on as well. So it is very important, honestly. Sometimes they give you ideas to what, because you are so, if it's not going well, you are so stressed and you're sweating, and then you're working with only half of your neurons at that time. And the technicians who are watching, who have been working with you, they're good with their hands, and they're very important. And some doctors, you might even see experts, they take their technicians with them to the workshops as well. So there must be something good with their technicians, and they must be something they're not comfortable with somebody else doing it. So very important. You can control the wire yourself as well, and but in my sometimes I do that, but majority of the time I depend on my technicians.
I think this is very important
Can I?
that one must invest. Just one message that I want to reiterate from Khalid, that every center must invest in their nurses and technicians. Saad, Saad,
Yeah.
you want to say something?
Yes. I'm. Thank you, Khalid. Thank you for an excellent talk, Khalid. Like always, and always the way you explain things. I think for everybody, including those who are relatively more experienced, it's always a joy to listen to and watch you explain things. A few points that I wanted to just elaborate on. So, one of the things that you mentioned in terms of failures, firstly, just taking this assistance point, I think the assistance role is important, but not so much in cannulation. Cannulation is primarily is related to your own expertise. And one of the things that you guys don't face there is the reuse of accessories. And one has to be very careful, because sometimes we tend to overuse the accessories, and the ampulla is, you know, traumatized quite often just because of the way your accessories are after reuse. Same thing applies to guide wires, papillotomes. So one has to be careful with that. And I think if you're having difficulty, take a look at your accessories if you're obviously reusing. We do. And I say this with experience, which I'm sure is something alien to Khalid, except when he comes to visit centers like ours. Second thing going on, Khalid, pancreatic duct stenting. I mean, I only put in a stent if I go in beyond 3 times, really. And then I put a stent, and then if I have to do a needle knife or whatever, then I would. Again, it's different because I think that adds to another, adds to the cost of stent, etc. So, you know, if you're getting into pancreatic duct, I agree that we should put a stent in. But if I'm going for a needle knife where I've not got into the pancreatic duct, then I would. Even if I get into pancreatic duct later, I tend not to do it. It's very interesting. We published in 2008 our experience with 515 patients. with Papilla that was available to us, and our success was almost 89% without needle knife, and with needle knife we got into 99.5% patients. The needle knife sometimes almost 70% of those required, we got in straight, and the rest most of them required a second session a week or a few days later. So it's interesting that our figures are very similar, and we've discussed this and we've discussed with Gayas as well. I wanted to ask you two things. How often, and I want to share our data as well, but how often do you fail in patients that are referred or failed elsewhere in your center? That's one question, Khalid. And the second question was number of cases that you fail and you refer to IR or use EUS in your practice, just general figure if you have any.
So I showed that study earlier, where I mentioned about 524 cases in our study of native papilla. 50 of those were failed outside, like not able to cannulate. So all of those 50 were cannulated. And 20% of those 50 means 10 cases almost, they were cannulated with either use of needle knife or beyond standard technique, but all 100% of those were cannulated. Where the papilla was reached, the cannulation rate is 99%, really, as long as it's the right indication. At that point, out of those 1% which are left, lot of those are not really normal looking papillas. They are either cancer or something else, major disease process. In those cases, we would use EUS guided. We can do that. And referring to IR for failed cannulation, honestly, I don't even remember when I did that last time. Just for failed cannulation. For Bill Roth, 4 patients which need a PTPD because internal stent didn't work. That's a different story. I'm talking about
when you got the ampulla.
When I got the ampulla, it was the right indication. I honestly do not remember when I sent it just for the cannulation purpose to IR.
Just quickly, I'll share, we are just in the process of publishing. We've done 170 cases that we have. Actually, we've done obviously a lot more, but 170 that we've looked at. Consecutive cases that were failed elsewhere, and we've got 170 success like yours. And significant percentage of those were done by, not myself actually, in our unit. It was done by people who've been trained and experienced, and I'm pretty sure that's something that's pretty universal, depending on the numbers and one's technique. I think one of the things, if I can just take 30 seconds here, Riaz, is it's very important to invest not only in your technicians. Without them, you cannot survive. Remember, your ERCP success is dependent on your technicians. Please respect them, treat them not like techs, treat them like your colleagues. And it makes a lot of difference. They'll give their, second point is please invest in accessories, scopes, proper x-rays, equipment, and last but not the least, anesthesia. A lot of failures occur because your patient is not properly sedated. I know people in Pakistan who've given, even for colonoscopy, 15 milligrams, 20 milligrams of midazolam and similar amounts of
Saad, we cannot hear you.
Oh, I can't hear him. Okay.
Saad, we cannot hear you. I think the connection has been lost. But I think Saad is very right in pointing out that we must invest in our units in terms of HR. We must invest in terms of accessories. We must invest in terms of equipment. And unless we have the right kind of equipment, infrastructure, and HR, the success rate is going to be compromised. And in that account, I think one has to follow the policies, one has to follow the international guidelines in terms of developing infrastructure, both equipment as well as um, space, and then uh, training your colleagues, meaning by technicians and nurses, and similarly training your younger colleagues. I should like to emphasize Khalid's point that if you failed on one day, that doesn't mean that that's the end of the world. In ERCP, you can fail. In ERCP or in any procedure, you can make complications. Important thing is that you should know how to manage the complication, and in case of failure, it doesn't mean that one needs to go aggressive. On the following day or day after, you can go in again, or one of your senior colleagues or some other colleague can go in again and complete the ERCP successful, unless it is very urgent. And this urgency kind of thing is extremely, extremely rare. There's a question from Dr. Atta, Khalid, that if you put in a wire in the pancreatic duct, what are your views about pancreatitis if it's just a wire?
I was reading that question. I was going to answer that. So, so if you get a wire into the pancreatic duct, and my principle is then go ahead and put a stent in there. And especially wire itself, when it goes into the PD, I know we always are very worried about a contrast injecting in there, but the wire itself can also cause a damage to the side branch. So if I get a wire, if wire is gone in there, not that I tried to go in there, but the wire is gone in there, and go ahead.
Yes, Khalid, go ahead.
Oh, okay. And wire is gone in there. In that case, I likely will go ahead and put a stent in the PD. If, however, I injected the PD but never got the wire in there, got the job done, I would not try to go into the PD to put a stent in there.
Agreed. I think it's very important to emphasize this point as well, that since the PD stent is quite cheap in Pakistan, one stent costs just 500 to 550 rupees. And it's very important to put in a single pigtail and not the straight pancreatic duct stent. So a single pigtail soft stent 5 French is going to cost you just 550 rupees. This is not a lot. An extra day's stay in the hospital, an extra injection of painkiller, maybe narcotic, that may be costing more. And this is not going to harm the patient. This is always going to benefit the patient. This is going to give you a good element of confidence that the patient is not going to get the pancreatitis. Saad is going to say something. I think he disagrees with that.
No, I disagree to the 551. Stents available at 550 rupees. At least not available to me. But having said that, my problem is that 5 French stents not always come out. And I've seen people put in 5 stents straight that have gone in, and that has caused much more catastrophe than maybe a little bit of pancreatitis that quite often occurs with. Second point is that if you are putting a stent and you go back, one of the reasons why I have this issue is, and I'm not saying at all that I'm right, but this is basically experience, and that is that you have to go back in and take that damn stent out if it doesn't come out, and that's another endoscopy. So that's okay in our center or centers which are obviously not charging, but when you are, then it becomes an additional cost to the patient. So you have to balance that, and obviously it's something that you're used to, and something that comes with experience as well. So we all have our own experiences, and some of the things we say are based on our experience. So it's not about one thing is right or the other is wrong. It's a question about what makes you comfortable, and whatever you are comfortable and your patient's outcome is good, I think you should just continue.
Yeah, I think it's also depends on your resources as well. And I agree, Gasbhai, with you. It's if we're going to put a PD stent just for prophylaxis purpose, there should not be any internal flange and should be a pigtail. So that have a better chances of falling out on its own.
Dr. A very interesting point has been pointed out by Dr. Turan, that it's funny that when we want to go get into the CVD, we are going into the pancreatic duct, and we want to go into the pancreatic, we're going into the CVD.
Well,
so what are your comments on that?
But that's everybody's dilemma, isn't it?
Suds law. One of the other thing is, Khalid, sorry, Gyas, if I add to that, I mean, failure when you're taking stones out in an ampulla that is visible is really, in my opinion, in good centers and good hands, really is something that doesn't occur. So if you're failing to take stones out, cannulate an ampulla or a papilla that has the indication is stone extraction, then you need to work on your technique or whatever it may be. But Khalid, we don't have this tendency of referral to a tertiary care, very rare, because we feel that when we refer the patient to the tertiary care, the patient will think that, oh God, that means there is somebody better. So that's one of the apprehensions, I assume. All the 170 cases that hopefully should be published soon were not referred to us. They had come out of their own finding out X, Y, Z. And I don't think this is something unique to us. All those who do a lot of cases would probably have the same thing. So I think for the relatively younger people or centers that are not doing that many, and I think numbers do matter. I don't know what your view is, and Riyas's, I would like to hear that. But the numbers make a difference, and if your results are not as good as some of the good colleagues internationally or nationally, then it's there is no harm. I mean, patient will always thank you. You may have failed, and I think when if I fail and I send the patient to Khalid and Khalid fails, it's a big morale booster. Yeah. Yes.
Yeah, that's right. There used to be a time when, for certain reasons, I used to refer the patients from Lahore to Karachi to Saad. When I still remember a case where the pancreatic stent had gone in, and I'd requested Saad to take it out in Karachi, and the patient was sent from Lahore. But at the same time, let me caution everyone that failed ERCP and failed cannulation, these are two different things. Failed ERCP is a different ball game altogether. Dr. Khalid has essentially focused on one thing, failed cannulation. Failed ERCP is a much broader term, and it always means that you can always take help from other colleagues. Towards the end of the day, patient should be winner. The system should be a winner. Nadeem, do you want to say something? Saad, you want to say something?
I wanted to say, just add there, one of the points Khalid mentioned was that we are overemphasizing on wire-guided cannulation and wire used. I practically hardly inject now, to be honest, in my practice. It's always wire into the duct that I want, if I'm lucky. And then once I've got the wire above the stricture, that's when I would inject. And that I know is the practice that you have, and I know Khalid also does the same. Most people in the world would do. The reason for that is that once you've injected and you're not able to get in a blocked duct or in a duct that has got stone, then you are actually now cholangitis and all the issues become much bigger problem. So I think it's important to try and do that if you can. But if, like Khalid mentioned, if you're stuck, then injecting gives you the route and an idea as to where you were going wrong, etc.
Yeah, my point was with regard to cannulation, just to get an idea about the roadmap. So instead of just keep pushing on the wire and it's not going in the right direction, but you think you are quite nicely engaged, it's a very minute injection. And just to get a roadmap, not above the structure.
Totally agree.
Yeah.
Nadeem,
you are on.
Thank you, Khalid Bhai. Thank you very much for an excellent presentation, as usual. Khalid Bhai, the question I have for you, rather, it's a comment, and I don't think I have guts to disagree with you, but I'm sure you know the rule of 10,000 hours to get good at something. So I think it does take a bit of a time, practice, a number of procedures before you can get somewhere closer to where you three icons of gastroenterology are. And I think it also depends on the trainer as well in the center where you're practicing. So if you're in a good HPV center with the support around you, then certainly you get better at it. More importantly is the decision making. I think technique clearly is important, but decision making is probably one of the most important things. The question I have is essentially two, Khalid Bhai. One is, what is your approach in cases where you have got a short duodenal sort of D1 segment and your scope keeps falling back once you are in sort of D2 across ampulla? And second question is, what do you do to minimize your risks in cases where you have planned a combined EUS and ERCP? Does the combined EUS ERCP make ERCP difficult or not? And then what are the ways to sort of minimize the risks if you have planned to do two procedures together? Thank you.
So first question is in the cases of B1, right? That's what you are talking about, like
yeah. So short B1 segment where your scope is not stable and you keep falling back.
Yeah. So in those cases, there are two things now. One is like those are adult patients where there is not much space for you. For me, I think it's a stable position is very important. What I have noticed in B1, sometimes you have to rest on the greater curvature and have the scope in there. So there's not much space between the wall and the scope. So it's kind of long or semi-long position to stabilize your scope. You can do that. Other times it's really, especially if you do a kid, which is a 1 year old, your scope is only literally 30 centimeter in there too. And so it's kind of comes into the same kind of scenario. So you really have to find your sweet spot and just find out where the scope is going to stay stable for you. And sometimes you have to lock the wheels. Other times it may be better not to lock the wheels. So it's really just depends on the scenario. So that's the best I can tell you about that. And second question was, if I got it right, like doing a EUS ERCP in the same patient in the same setting, does that make the ERCP difficult? In my experience or practice, I don't think so, because we do EUS ERCP together all the time, and the majority of our patients are getting a EUS and then ERCP right after that. So for me, it does not make a difference, and I don't think it really should make one or the other procedure difficult.
Thank you.
Okay.
Sir, do you want to say something, or should we back
No, I think we've already passed.
I think it's already 10 minutes overtime, and Khalid is on a beach, and we are keeping him away from the beach. I'm really thankful to Khalid for sparing his time while he was on a vacation. It remains for me to thank all the participants, my colleagues, Dr. Saad Pias, Dr. Nadeem Thiami, Dr. Junaid Mushtaq, and I'm at the same time thankful to Wilson Pharmaceutical for providing us with a platform.